Hi all, once again a warm welcome to my YouTube channel Future Midwife. Today's our topic is induction of labor. Induction of labor is a medical process where labor is initiated artificially, typically through medication or other interventions, in order to help a woman to give birth vaginally. This procedure is usually recommended when the risk of continuing the pregnancy outweigh the benefits, such as in case of postpartum pregnancy, fetal distress, or maternal health complications. Induction of labor aims to stimulate uterine contraction, helping the cervix to dilate and the baby to move through the birth canal. While induction can be a life-saving intervention, it's essential to understand the reasons, methods, and potential risk involved. So let's move on to our today's topic, induction of labor in detail. First of all, we start with the indications for induction of labor. The indications will be categorized into two, maternal indications and fetal indication. First, we will see the maternal indications, which include postpartum pregnancies, that means between 41 to 42 weeks of gestation, hypertension disorders of pregnancy such as preeclampsia, eclampsia, and gestational hypertension, diabetes mellitus such as pre-gestational or gestational and poorly controlled diabetes mellitus. The last one is maternal medical conditions such as renal disease, heart disease, etc. When it comes to the fetal indications, which include intrauterine growth restriction, intrauterine fetal death, oligohydramnios, and Rh isoimmunization with the complications. Next, we'll discuss about contraindications. That also divided into two, absolute contraindications and relative contraindication. The absolute contraindication include cephalopelvic disproportion, placenta previa or vasa previa, transverse lie or abnormal lie, cord prolapse, previous classical caesarean section or extensive uterine surgery, and active genital herpes infection. The relative contraindications include previous lower segment caesarean section, grand multiparity, and fetal distress. Before moving to the induction procedure in detail, we will see the pre-induction assessment, which include confirm the indication. Next is assess the gestational age and fetal well-being. Next is very important, find out the Bishop's score. If the Bishop's score is less than 6, which indicate cervix is unfavorable for the induction, then we have to go for the intervention in order to ripen the cervix. If the Bishop's score is more than 6, which indicate the cervix is favorable for induction, then we can move on to induction procedure. Here I will explain about the method of induction. Usually we have three types of method of induction, such as pharmacological, surgical, and mechanical. In case of pharmacological, we are using drugs in order to ripen the cervix. These are prostaglandins and oxytocin. When it comes to the surgical, which include membrane seeping or striping and amniotomy. The third one is mechanical, which include balloon catheter or double balloon catheter induction. Now I will explain about pharmacological induction of labor in details. In that, first drug of choice is prostaglandin. Prostaglandins are the first line agent for cervical ripening and induction. Types used are PGE2, example dinoprostone, which is available as gel, pessary, or insert forms. The PGE1 also another type of prostaglandin, which we called it as misoprostol. Usually these types of drugs are anti-ulcer drugs but widely used off-label for induction. The mechanism of action of prostaglandins are cervical ripening, stimulate uterine contractions, and increase gap junction formation. In case of cervical ripening, it softens the cervix by breaking down collagen and increasing the water content. So in case of stimulate uterine contraction, usually it increases intracellular calcium in myometrial cells and automatically it stimulate uterine contraction. Also, it increases the gap junction formation, which helps for the proper coordination of uterine contraction. By these three ways, the prostaglandins induce cervical ripening. Here we'll discuss about the preparation and dosage of prostaglandin. I already told you it is available in the two forms, that is dinoprost and misoprostol. In case of dinoprostol, it will be available in two forms like gel and pessary. In case of gel, we have to apply 0.5 mg intracervically. It can be repeated after 6 hours. Maximum we have to give 3 doses in 24 hours. When it comes to the pessary form, 10 mg controlled releasing vaginal tablet has to be inserted. It helps to release slowly over 12 to 24 hours. In case of misoprostol, it will be available as oral tablet or vaginal tablet. Oral misoprostol is usually given in 2 to 4 doses of 200 micrograms per day, and the time to maximum concentration is 10 to 20 minutes. In case of vaginal tablet, 25 mg vaginally every 4 to 6 hours. Maximum 4 to 5 doses in 24 hours. If it is high dose, that means more than 50 mg, which increase the risk of uterine hyperstimulation and rupture, especially in case of scarred uterus. Next drug of choice is oxytocin. Oxytocin is used after cervix is favourable or after prostaglandin ripening. The mechanism of actions are, it acts on the oxytocin receptors in myometrium, it increases the intracellular calcium and it leads to muscle contraction. Also, it enhances prostaglandin release, which automatically augment the uterine activity. Next, I will explain about the oxytocin induction procedure and dosage. Oxytocin is administered intravenously via an infusion pump for precise control. The standard preparation involves diluting 10 units of oxytocin in 1000 ml of normal saline or Ringal latte to get a solution with a 10 milliunits per ml concentration. The initial infusion rate typically starts at 0.5 to 1 milliunit per minute, which is equivalent to 3 to 6 ml of the diluted solution per hour. The dose is then gradually increased by 1 to 2 milliunits per minute every 32 to 60 minutes until an adequate contraction pattern is achieved. If the mother is getting contractions every 2 to 3 minutes, which is lasting 40 to 60 seconds, is considered as good uterine contraction. Once labor progress, that means if the mother attained the cervical dilatation 5 to 6 cm and desired contractions are reached, the dose can be reduced. Maximum safe infusion rate generally do not exceed 6 to 10 milliunits per minute at time. Continuous fetal and contraction monitoring is essential to avoid hyperstimulation or fetal distress. If contractions are too strong or frequent, the infusion should be stopped immediately. Induction of labor is a long topic, so I plan to wind up this section now. The mechanical and surgical induction will be continued in the next section. Thanks for watching my video. We'll see you next time.